We reported our new data and findings in the 40th European Society of Lymphology Congress in Genoa in 2014. Please share and enjoy our slideshow with your lymph friends. I'm constantly being asked questions like this by patients with lymphedema. Which is more effective, conservative therapy or surgery? I first tell them, it depends on you. Today, I want to discuss 3 new topics concerning lymphedema. First, understanding abnormalities in one's endolymphatic pressure. Second, understanding the mechanisms of the treatments for lymphedema. And third, the importance of choosing the therapy that is most appropriate for oneself. Let me address the first topic in detail. The upper row shows the International Society of Lymphology, we call ISL, classification for lymphedema. To date, lymphedema severity has been evaluated based on clinical appearance, such as thickness and the skin abnormalities. We propose a severity classification based on the function of the lymphatic vessels. The lower photographs show changes that occur in lymphatic vessels of the lower limb after surgery for gynecological cancer. We found a high degree of correlation between the ISL classification in the upper row and the changes in lymphatic vessels in the lower row. The leftmost photograph is of a normal collecting lymphatic vessel. Such vessels autonomously contract and expand when lymph flows through them. The second picture from the left shows a collecting lymphatic vessel after lymph node dissection. The flow of lymph has stagnated and the vessel is constantly dilated. If this persists long-term, the vessel will gradually harden and lymph will begin to leak from it. The rightmost photograph shows a lymphatic vessel that exhibited frequent cellulitis and eventually fibrosed and lost its function. These images show the dynamic changes that take place in lymphatic vessels after lymph node dissection. The upper row shows a schematic diagram of collecting lymphatic vessels. The most important feature of these images is endolymphatic pressure. Normally, lymphatic vessels autonomously contract and expand. In early-stage lymphedema, endolymphatic pressure rises abnormally due to stagnation that occurs after lymph node dissection. In the chronic stage, there is an abnormal growth of intramural smooth muscle inside the lymphatic vessels to counter the increase in internal pressure, which causes the walls to gradually thicken and the lumen to narrow. Eventually, there is damage to the lymphatic endothelial cells, which causes lymph to leak outside the vessels. Finally, fibrosis occurs and the lumen becomes blocked. We analyzed changes to collecting lymphatic vessels by light microscopy. The top row is the schematic diagrams shown previously. The second row shows smooth muscle cells, and the third shows mainly lymphatic endothelial cells. I'll first discuss the smooth muscle cells in the second row. From left to right are the normal early chronic and terminal stages. In the normal stage, smooth muscle cells overlap in the vessel wall. Then, in the early stage, increased endolymphatic pressure causes the smooth muscle cells to become thin and stretched out. If this continues, there is an abnormal growth of smooth muscle cells, which causes the walls to thicken markedly and the lumen to narrow. This is the chronic stage. In the terminal stage, the lumen is blocked and lymph function has been lost completely. Next, we will examine the lymphatic endothelial cells in the third row. Endothelial cells prevent lymph from leaking outside the lymphatic vessel lumen. When internal pressure rises in the early stage, we observe intense activity of the lymphatic endothelial cells to prevent leakage. In the chronic stage, endothelial cell damage begins to appear, and gradually lymph begins to leak from the lumen outside the collecting lymphatic vessel. Eventually, endothelial cell function is completely lost. Lymphedema appears when this leakage begins. In other words, changes to the lymphatic vessels begin before the onset of lymphedema, and the pathology advances gradually. An electron microscope gives a more detailed view. The left image is of a normal collecting lymphatic vessel. There is a thin layer of lymphatic endothelial cells, then smooth muscle cells and collagen fibers from the media to the adventitia. Lymphatic endothelial cells can be seen protruding hill-like into the lumen. The right image shows lymphatic endothelial cells in the early stage. The cell's shape has changed to accompany the rise in internal pressure, becoming stretched out into paper-like sheets. Let's examine changes to endothelial cells more closely. In the normal stage, the areas where lymphatic endothelial cells adhere to each other, the desmosomes, are bound very strongly. This adherence gradually loosens in the early stage, until in the chronic stage some adhered portions come loose. This is very much like a piece of rubber that is stretched until it finally snaps. The image on the lower left is a three-dimensional depiction of closely overlapping endothelial cells in the lymphatic vessel lumen. Note, there are no gaps. The lower right image shows the chronic stage. Some endothelial cells have fallen away, exposing the collagen fibers of the media to the lumen. We believe lymph leakage occurs from these areas where endothelial cells have fallen away. Let's examine the changes to smooth muscle more closely. To state the conclusion first, the findings strongly resemble those seen in arteriosclerosis. This was first reported by Dr. Ogata in 2009 and by our team in 2012. The secretory smooth muscle cells of the normal stage transform into undifferentiated smooth muscle cells in the chronic stage. There is abnormal growth of these transformed undifferentiated smooth muscle cells, causing the walls to thicken quickly in response to increased internal pressure. Also, components that promote the formation of collagen fibers begin to be secreted from cell surfaces. The walls of the collecting lymphatic vessels gradually thicken and the lumen narrows. These are 3D images of collecting lymphatic vessels. The left image is of a normal vessel with a sound lumen. However, the chronic stage image on the right shows an abnormal thickened wall and an extremely narrow lumen, like a pinhole. Other researchers have reported on endolymphatic pressure. In 1980, Polish Dr. Olszewski reported that normal endolymphatic pressure in humans is about 30 millimeters of mercury, though this can rise to over 100 millimeters of mercury after lymph node dissection. Such an increase in internal pressure produces not only edema, but causes patients to complain of symptoms involving pain and discomfort. I believe it is important to treat abnormally elevated internal pressure. These photographs show me receiving conservative therapy from a trusted lymph therapist. As you can see, it's a fun memory. After studying the theory and experiencing therapy, I understand the aim of conservative therapy to be increasing endolymphatic pressure. Artificially elevating endolymphatic pressure is intended to drain lymph through non-physiological locations, such as the axial or contralateral groin lymph nodes. As such, for surgical therapy, I would like to discuss lymphatic venous anastomosis. The essence of this method's mechanism is the use of a pressure gradient. Pressure in collecting lymphatic vessels after cancer therapy can rise to 50 millimeters of mercury or higher, while normal venous pressure is 10 millimeters of mercury at most. Directly anastomosing a lymphatic vessel to a vein brings the pressure inside the lymphatic vessel down to the vicinity of venous pressure, which results in lower endolymphatic pressure. Thus, this therapy is effective when endolymphatic pressure is elevated. I feel it is very important to select the most appropriate therapy for each individual patient. Arguing over whether conservative therapy or surgery is better is meaningless. In the early stage, when internal pressure is elevated, surgery should be selected, while in the chronic and terminal states, when internal pressure declines, conservative therapy is best. However, our experience has shown that combining conservative and surgical therapies can achieve even better effects. Each is essential. The second thing I tell patients is to find out what their endolymphatic pressure is before beginning treatment. Our team uses lymphoscintigraphy to evaluate endolymphatic pressure, the results of which can greatly impact the therapeutic effect. Case 1 is a lymphoscintigraph from a healthy person. Isotopes injected in the insteps of both feet reached the groin on both sides in about 10 minutes and arrived at the heart in about 20 minutes. The other images are lymphoscintigraphs from patients that underwent pelvic lymph node dissection. Good lymph function remains in case 2, while it is clear in case 3 that the right leg has reduced lymph function. Lymph function in both lower limbs has completely disappeared in case 4. I would recommend case 2 undergo surgical therapy and case 4 receive conservative therapy. Case 3 is receiving a combination of conservative therapy and surgery. We treat our patients by combining surgery with conservative therapy. After at least 3 months of conservative therapy, surgery is performed if the patient desires further improvement. This patient experienced lower limb lymphedema after gynecological cancer surgery. The edema occurred over a course of nearly 16 years, but good lymph function remained, so LVA produced marked improvement. This patient experienced bilateral upper limb lymphedema after breast cancer surgery. Her condition improved after LVA. This patient experienced facial lymphedema after head and neck cancer surgery. LVA was performed on both sides of the lower jaw, which reduced the edema. The edema eventually improved, and a facelift was performed to remove excess skin. This patient underwent LVA in the lower limb for a lymphocele formed after surgery for gynecological cancer. The pelvic cyst disappeared by the 2nd month after the operation. My final answer to patients is to tell them that their lymphedema can be improved. Thank you for your attention.